December 2017, Paper 3. Few of the questions have been discussed in previous classes. It is the continuation of that. Today's question is approach to child with joint pain. So if any child presented with joint pain, if child is coming into the OPD with joint pain, we should do the triage first. We should categorize the child. Do triage first. See if the child is toxic or the sick looking or the non-toxic, so that we can start the management. If child is toxic, that means child is having red flag sign. What the red flag child will be showing? If child is having high grade fever, acutely swollen and hot joint will be having swelling and it will be warm, and child is unable to bear weight, or unable to move the joint. If these signs are there, we should suspect septic arthritis or osteomyelitis. This condition is an emergency, so do urgent aspiration and start IV antibiotics. If the child was toxic looking or sick looking, but if child is non-toxic, non-sick, that means child doesn't have fever, child is febrile, the pain was chronic, and child can move limbs slightly. So in this case, we'll start the stepwise approach to know the cause. In this, we'll start with focused history. After that, we'll do targeted examination. Then we'll order some laboratory investigations. and imaging, and then we'll start treatment after knowing the cause. So we'll do triage and then start treatment accordingly. We'll start with stepwise approach. First is focused history. Ask the history of onset and duration. Acute or chronic. If pain is intermittent or persistent. Ask about the pattern. If it is affecting only one joint, monoarticular. If it is oligoarticular. Or if it is polyarticular. Take the history of number of involvement of the joint. Then associated symptoms. If there is fever, rash, history of weight loss, morning stiffness, or if there is any history of trauma. Or additionally, there is recent sore throat, diarrhea, or family history of any autoimmune disease. Is there any functional impact? Like the child is limping, refusal to walk or the daily activities. This is the focused history. That is to guide the differential diagnosis. Second step is physical examination. First is general physical examination. Check about the growth, pallor, lymphadenopathy, and check for hepatosplenomegaly. After general examination, do the joint examination. Check for the characteristic of swelling, any warmth present, the range of motion, tenderness, if there is any effusion, and also compare this joint with contralateral joint. Also check for extra-articular sign. Rash, which is seen in case of SLE and systemic JIA. Uveitis. Check for nail pitting. Nail pitting is a feature of psoriatic arthritis. After the physical examination, order some laboratory investigations. Basic investigation: CBC, ESR, CRP. Specific test: ASO titer, ANA, rheumatoid factor, and HLA-B27. And go for imaging. X-ray of the joint, ultrasound if there is any effusion, and MRI if needed. If you have done joint aspiration, then send gram stain, culture, and cell count. After investigation, last is management. Supportive management: give analgesics, give rest to the joint, applicable, start physiotherapy. And then targeted therapy in selected cases. Antibiotics for septic arthritis. NSAIDs, DMRDs for JIA. Steroid or immunotherapy in case of SLE and vasculitis. After identification of the cause, start the management. This was the approach to child with joint pain. So always categorize the child in toxic or non-toxic if child is sick looking or the well looking. After categorization, start the focused history, physical examination, investigation, and lastly management. Next question. Drug treatment for urticaria. Urticaria is basically a histamine-mediated disorder. The drug therapy include first line therapy is second generation H1 antihistamines. Second generation H1 antihistamine is the drug of choice. The mechanism of second generation H1 antihistamine is they block H1 receptors. Advantage of this drug is it is non-sedating. It has longer duration of action. So once daily dosing is enough. and it has minimal anticholinergic side effect. The examples: cetirizine, levocetirizine, loratadine, desloratadine, and fixofenadine. Duration: in case of acute urticaria, you should give it for 5 to 7 days. If it is chronic urticaria, then we need to give it for weeks to months. But in spite of giving this second generation H1 antihistaminics, if symptom persist, after 1 to 2 weeks of standard dose, that means if symptoms start appearing after stopping the doses, then we can increase the dose. Increase the dose 2 times. If needed, we can increase the dose 4 times. Because these second generation H1 antihistamines have minimum CNS penetration, so these are the drug of choice, and it is first line therapy. Second category of drugs: first generation H1 antihistamines. But the drawback of these are they are sedating and they have anticholinergic side effects. So what are the indications why we use them? As it is sedating, so we use it in case of severe nocturnal pruritus. The child is unable to sleep because of itching. Acute distress interfering with sleep. Example: hydroxyzine, diphenhydramine, and chlorpheniramine. Third is adjunctive therapy. These are H2 antihistamines. These are used as only add-on therapy. It never given as a monotherapy. The principle of these medication are dual blockage may enhance control. Dual blockage means we never give H2 antihistamines alone. We should always give it with H1 antihistamines. So H1 along with H2 antihistamines causes dual blockage and it enhances control. The example of H2 antihistamines: famotidine and ranitidine. Fourth is leukotriene receptor antagonist. Indication: NSAIDs-induced urticaria or the drug-induced urticaria. Physical urticaria. Or there is partial response to antihistamines. So we can add on these drugs. Most common example is montelukast. The fifth category of drug is corticosteroid. The mechanism is it suppresses the mast cell mediator release. It is indicated when severe acute urticaria, if there is angioedema, that means the swelling of lips causing functional impairment. Acute exacerbation not responding to antihistamines. So it is given in case of emergency situation. Example. Oral prednisolone and it is given for short duration only, 3 to 5 days. Advanced therapy. We use omalizumab. This is anti-IgE monoclonal antibody. And this is reserved for refractory cases. And the last is if there is urticaria with anaphylaxis. That means patient presented with breathing difficulty, or the hoarseness of voice, or the hypotension, or the syncope along with urticaria, urticarial rashes. This is the emergency condition. And treatment is IM adrenaline. So that's all about the drug treatment of urticaria. First line therapy, second generation H1 antihistaminics. We can add first generation H1, then H2 antihistaminic, leukotriene receptor, corticosteroid, omalizumab, and the condition with anaphylaxis. Next question. Diagnosis and prevention of congenital rubella syndrome. We will start with diagnosis. Of congenital rubella syndrome. So first start with maternal history. If there is a history of febrile rash during the pregnancy. Especially during the first trimester. Infant clinical feature. These are classical triad. It includes sensorineural deafness, second is congenital heart defect, like PDA, pulmonary artery stenosis. If there is any ocular defect, like cataract or retinopathy or microphthalmia. So these are the classical triad of congenital rubella syndrome. Other features. You can also get microcephaly in the child, hepatosplenomegaly, classical blueberry muffin rash, it is the thrombocytopenic purpura, and then later on developmental delay. These are the features we get to find in the infant. And after clinical features, laboratory confirmation. First, mother, maternal serology, presence of rubella IgM positive titer or the rising IgG values. In case of infant rubella IgM positive, this is the strong evidence for the persistence of rubella IgG beyond 6 to 12 months. And this indicates endogenous antibody. And not the maternal transfer. Because maternal antibody persists only till 6 months. Then RT-PCR for rubella RNA from throat swab, urine, blood to confirm the viral presence. So this is the diagnosis of congenital rubella syndrome. Take maternal history. If there is history of maternal fever with rash, infant clinical picture which include classical triad, and then laboratory confirmation. The method of prevention of congenital rubella syndrome. So first is universal immunization. This is the most effective method. And this immunization given as MMR or MR. First dose is given at 9 to 12 months. And the second dose is 15 to 18 months. This person has universal immunization. And then there is a chance of preconception immunization. In this, women of reproductive age should be screened for rubella immunity. And non-immune women should receive MMR vaccine at least 1 month before conception. During pregnancy, MMR is contraindicated. Because it is live vaccine.
Yeah. 5 बात होती है।
Next is postpartum vaccination. The postpartum immunization. If you don't get the chance to immunize during the preconception period, during pregnancy it is contraindicated, then to all non-immune mothers should receive MMR vaccine after delivery. These were the vaccination measures or immunization measures to prevent the congenital rubella syndrome. And lastly, infection control measures. So congenital rubella syndrome infants. These infants should be isolated in hospitals and managed with droplet precautions to spread the infection to the others. So this is about the congenital rubella syndrome, diagnosis and prevention. Next question. The current therapy of Kala Azar. So what is Kala Azar? Kala Azar is a systemic protozoal infection which is caused by Leishmania donovani. Kala Azar is also called as visceral leishmaniasis. And it is characterized by fever, hepatosplenomegaly, pancytopenia, and weight loss. The therapy for Kala Azar will start with first line therapy. It is the liposomal amphotericin B. This is this single dose regime. The dose is 10 mg per kg IV. This dose is highly effective and well tolerated. But if single dose regime is not tolerated, then there is alternative regime. We can give it in multiple dose. That means 3 to 5 mg per kg IV on day 1 and day 3. First line is liposomal amphotericin B. Then alternative therapy. The drug is miltefosine. And this is the oral drug. The first oral agent for Kala Azar is miltefosine. It is used in children more than 2 years of age. The dose is 2.5 mg per kg per day, and duration is long for 28 days. And side effects are GI intolerance, and it is teratogenic. The second alternative therapy is paromomycin. This is the IM, intramuscular therapy. Paromomycin is a aminoglycoside antibiotic. It is given as daily IM injections. For 21 days. To make the compliance better, there comes the combination therapy for shorter duration. It comes under National Kala Azar Elimination Program. It includes single dose liposomal amphotericin B plus miltefosine for 7 days, or we can give single dose liposomal amphotericin B plus termomycin for 10 days. Along with drug therapy, the nutrition and supportive care, treat anemia, correct the dehydration, and manage if there is any secondary infection. So this is the therapy of Kala Azar. Next question. Management of congestive cardiac failure or congestive heart failure. Congestive heart failure is a clinical syndrome in which heart is unable to meet the metabolic demand of the body. Resulting in pulmonary or systemic congestion. As soon as the patient of CHF arrives, first of all, okay, start the immediate stabilization. Give proper positioning to the patient. Semi-upright position. Secure airway. Give oxygen if required. Immediately give IV access. And after that, fluid and salt management, which is very important in CHF. Restrict the fluid to reduce the load on the heart. Restrict fluids and also restrict the sodium intake. and strictly monitor input output and daily weight to assess the fluid status of the body and the load on the heart. Then comes, after stabilization, start the medications. Pharmacological therapy. Various medications are available to treat the CHF. Most important is diuretic. So it is the first line agent. Loop diuretics. We can also use spironolactone. Potassium sparing diuretics, depending upon the electrolytes. So diuretic causes rapid symptomatic relief. By decreasing the preload. After diuretics, AC inhibitors. Captopril and enalapril are the example. The mechanism is they reduce, their work is afterload reduction. How they reduce afterload? They reduce systemic vascular resistance, so by reducing systemic vascular resistance, it improves forward flow of blood. And also decrease the myocardial remodeling. You can also give inotropic support. Example is milrinone or the probutamine. They are indicated if there is decompensated heart failure, or if there is cardiogenic shock. Digoxin, the important drug. It improves myocardial contractility. It also controls heart rate. Beta blockers. The carvedilol. It is given in selected cases. For example, dilated cardiomyopathy. The pharmacological management, the monitoring, monitor weight, intake output, and do some baseline workup like CBC, electrolyte, renal function, liver function, ECG, chest X-ray, and echocardiography. And the definitive therapies include in case of congenital lesion, timely surgical correction, or the catheter correction. So this is about the management of CHF, congestive heart failure.